All right, so I'm Chauncey Spears. I'm going to give a talk, really kind of a basic talk on mood and psychosis in Parkinson's disease. Before I go too far into the talk, I just want to make sure that everybody knows. I know there are two different sessions going on right now. There's this one about mood and psychosis that I'm going to deliver, and then Heather Simpson, one of our occupational therapists here, is giving a talk next door on some of the some other symptoms of Parkinson's disease, specifically things like sleep and hyperkinetic movement disorders. At the Movement Disorder Center, I'm one of the Movement Disorder Fellows. So I was trained in neurology up in Pittsburgh before coming down here for these 2 years. And I know I've seen a lot of familiar faces, and it's because I get to jump around in clinics and work with Dr. Oken, Dr. Hess, Dr. Malati. Really, I have the luxury of just bouncing around and seeing patients with all the providers at the center. Just so I know, and I think I saw some hands raised earlier, and I think this is a good exercise, how many people here have Parkinson's disease? If you could raise your hand. Okay, good. Now, of those patients, of those who have Parkinson's disease, how many believe or think that they might have a problem with mood or psychosis? All right. Now, next thing I want to do is, if you have Parkinson's disease, close your eyes. And how many family members, caregivers, significant others are here with them? Okay. All right, and still with everybody with Parkinson's disease, still with their eyes closed. How many, from the caregiver side of things, raise your hand if you think your significant other has problems with mood or psychosis. Okay, now everybody put their hands down. All right, now everybody can open their eyes. And so, and this is really a really important exercise, because mood and psychosis are very common problems in Parkinson's disease, but they don't have a lot of awareness associated with them. And the patients with Parkinson's disease, they may not realize that they have problems with mood or psychosis, but it's usually significant others that bring it to our attention. So we'll talk a little bit more about that as we go. While mood and psychosis are common in Parkinson's disease, what we really see, and if you're not a patient or you don't know somebody with Parkinson's disease, this is what a lot of people think Parkinson's disease is, right? This type of picture, where you're hunched over, you're shuffling when you walk, you have that masked or poker face, and you may have a little bit of a tremor. And these are at large the motor symptoms, or the symptoms related to movement or motion that are related to Parkinson's disease. But we know that Parkinson's disease carries many, many more faces than that. And we're seeing now, and now that we're getting beyond and more folks are aware of the diagnosis of Parkinson's disease, we have a lot more people, especially a lot more celebrities that have Parkinson's disease. We're beginning to see that, all right, Parkinson's disease, it has a lot more faces. There's a lot more out there besides just what we see with Michael J. Fox. And that's because, and Parkinson's disease is not a disease that just affects the dopamine areas of the brain, and dopamine is that chemical that we usually translate of, this affects movement and motor. But Parkinson's disease, especially as it progresses, as you see it moving on, and on this picture right here, all those areas that are kind of pink, purplish, red are areas affected by this disease. It affects other chemicals in the brain, really just the same, not just dopamine, but also norepinephrine, which is otherwise known as noradrenaline, and kind of gives us that spunk, motivation, kind of that attention. It affects serotonin, which helps control mood and anxiety. And then it really involves the brain at large. But we don't give these other aspects of the disease, these other chemicals that are affected in Parkinson's disease, a lot of respect. But we know, and I think as providers, we know that on the left here, you see the motor symptoms of Parkinson's disease, and there are quite a few. On the right, you see all the non-motor symptoms, and these are symptoms that are beyond just movement, things like depression, things like anxiety, things like problems with sleep, constipation. This list of non-motor symptoms far outweighs, and almost, in this case, is almost twice as large or twice as long as the motor symptoms of Parkinson's disease, and I think we're going to expand a little bit upon that today. And we're going to talk about two distinct categories of symptoms in Parkinson's disease. First, mood and psychosis. And it's important to understand that mood and psychosis, first and foremost, they may very well be just a normal reaction to being diagnosed or told you have that diagnosis of Parkinson's disease. That's normal. That's normal to have that reaction, that stress. But mood and psychosis, even beyond that, are part of this disease. Right? These are part and parcel with this disease, and it's not just your reaction to it, but this is again, really the responsibility of how the disease is acting. So first focusing on mood and anxiety, and mood, rather, we're going to break down into three main categories. We're going to talk about anxiety, apathy, and depression. First focusing on anxiety. And I can say that I've been here. I mean, I had to go through neurology residency. I was in the hospital a lot. And there were times in the middle of the night getting called that this was me. I'm still kind of like that even. But we all experience this, and we all can relate to just being really frazzled. And anxiety, at least by definition, anxiety refers to this distress or uneasiness of mind. That can be due to a number of things. It can be just due to fear, all right? And especially in Parkinson's, due to fear of falling, or maybe even fear of getting up after you fall. It could be fear of, all right, am I going to get that next dose of medication right on time, right at that 3-hour mark or 5-hour mark? Or the doctor said 7, 12, and 7, I need to take it right at those times. There can be fear and anxiety associated with taking the medication or missing the medication. And that really kind of belays into, fear of what's going to happen if I do miss the medication? Am I going to have the tremor that comes back? Am I going to have freezing, which could lead to falling? So anxiety is a big part of Parkinson's disease. And it's common, right? Anxiety can affect up to about 30% of patients with Parkinson's disease at some point. That's about 1 in 3, all right? About 1 in 3 folks. But we're fortunate in that anxiety is one of these things that, while it affects a lot of patients with Parkinson's disease, we have ways to combat it. We have a number of different effective therapies to treat it after we first recognize it. And on that front line, right, really first and foremost, we do like to take that kind of more conservative approach, doing things like behavioral therapies, psychology, counseling. And these can sometimes come with a really kind of a negative connotation of, I don't want to see a shrink. I don't need to see somebody like that. But this, by all means, is that first step and really can help us tackle those stressors that lead to anxiety. How to first identify them, how to kind of put the blanket over them and calm them down a little bit, and also really more constructive and healthy ways of dealing with that stress that we may come up with. So this is really the first strategy, the first therapy in treating them. And beyond that, after we take that first step, or if it is pretty considerable, seeing a psychiatrist or even sometimes us in clinic will prescribe medications that can help treat that kind of chemical imbalance that we see in anxiety. And a lot of these medications, and we have a bunch, a lot of these medications are the same type of medications that we might use in treating things like depression. And a lot of medications, there are things that we might use in Parkinson's otherwise, like the benzodiazepines, clonazepam or Klonopin for RBD or kicking and moving around at night. So these are frequently used medications, and as long as they're used appropriately, by all means, it's something to consider. Next, I want to move over to apathy. And apathy is a tricky one because it's under-recognized and it's not really, and it's hard to define, really. One of the ways I think about apathy, and I grew up in the Garfield era, I'll say, and Garfield to me represents that apathy. He wasn't depressed, he wasn't down, he just was kind of meh. All right, Garfield just sat around, he was lazy maybe, but there are certain things, and while never gloom, there are certain things that would inspire him to get up and move. I think lasagna being the big one. And then I think picking on that dog, Odie, I might be the name, I don't know, don't quote me, was kind of the other thing. So he had things that kind of got him going, but he lacked that motivation, that interest in things otherwise. And that's the definition of apathy. That absence or suppression of passion, emotion, or excitement. And I'm from West Virginia originally, I say gumption. Gumption is my word that I use for apathy. But it's that lack of interest in things. Kind of like this cat here, just being a couch potato, sitting there, not really engaged or interested in things. Now, apathy in this context of Parkinson's disease especially, apathy is tricky because As a patient, as somebody with Parkinson's disease, if you're apathetic or not very interested, you may not say, yeah, I'm not interested, I'm apathetic. You may just not be engaged, whether it be engaged in wanting to go exercise, wanting to go be involved in social activities, wanting to take your medications on time. And oftentimes, especially I think as a family member, as a friend, as a caregiver on this side, sometimes we can view that view apathy as, oh, they don't want to do anything, they don't care, okay? And that's tricky. I think it's very tricky, and I think we see it a lot in the clinic of caregivers, especially, and family members struggling with, all right, well they don't want to do anything. Well, what do we do? Well, that's apathy that we're dealing with. But apathy is not depression. Apathy is not depression. It's good to make that distinction, because a lot of the times when we see apathy and isolation, you're not necessarily down. If we ask Garfield, hey, are you sad? Are you gloomy? He'll be saying, meh, no. They're just not interested. They're not necessarily sad or gloomy. So the treatment of apathy, as opposed to anxiety and depression, it can actually be a little bit more challenging. And you got to imagine, if you're apathetic and don't want to engage in the treatment, that right there is already a challenge or hurdle that we have to overcome. But it's important to do these things, and it's important to get involved in really kind of structured activities. All right, set the calendar, set the schedule. You're doing this. All right, set up nice routines. And this could be, and I think we saw some of these things earlier, which was awesome. I mean, this could be things like dancing. All right, dance groups that you're going to dance every Wednesday, dancing Wednesday. Or other activities where you get out and you're kind of forced to have the socialization. Routines are another really important thing to have, and that kind of comes with this structured activity. Another thing, and this kind of goes and speaks for what we saw earlier, are these type of groups which really kind of motivate people. Find what motivates you, and if it's boxing and hitting a dummy, not another person, I mean, if that's what motivates you, get out and do it. And boxing is one that's amazing, and a lot of patients really enjoy just getting out there. And it's also a group activity, so that's another way to kind of counter apathy. And then we'll move on to the last thing, and the last thing I'm going to talk about under the category of mood, and that's depression. And when looking up the definition for depression, kind of outside the medical literature, it was kind of stagnant or stale. They described depression as, well, it's the act of depressing, or the state of being depressed. I related it when I'm using kind of cartoon characters to relate some of these things. Rather than Garfield, I relate depression to more of an Eeyore. Right? More of an Eeyore, not just gloom, not just uninterested or disinterested in things, but down and sad. And with depression, while the central feature of depression is often a problem with mood, being down or depressed, there are a lot of other features that come with this, a lot of extra baggage that comes with depression. And when you volunteer, whether it's patients or family members of somebody that is depressed, we usually go off into asking these type of questions, because depression can affect concentration, okay? It can affect memory, and sometimes patients may think or may kind of showcase themselves as having a dementia or a memory problem, but truly at the base of it, they're depressed. It can, of course, involve things like energy, interest in activities, and even kind of overflow or overlap a little bit with apathy. Appetite can be suppressed, and you can start actually losing weight. It can affect sleep, both in the plus and minus, sleeping too much or not sleeping enough. So again, when we talk about depression, it's not just mood, but it is multifactorial, and it affects, really reaches out to a lot of different aspects in the day. And depression is very common. Of everything that I'm going to go over today with mood and psychosis, depression is probably the most common. And we know that about 50%, so 1 in 2, right, every other, I mean, you do a coin flip, every other patient with Parkinson's disease has the likelihood of developing depression at some point during their disease. This could be early, this could be late, this could be right in the middle. I mean, 50%. So it's very, very common. And depression has a heavy impact, a very heavy impact on quality of life, even more so than tremor, even more so than rigidity or stiffness or falls. Depression can have the higher impact and impairment on quality of life than any of these things. And it also not only impacts, the patient, but depression really impacts the caregiver, the family, the friends, because you don't want to see your loved one in that state. And it can also, of course, involve family and friends. So treatments for depression, and first and foremost, just like treating anxiety, it's good to approach this, and this will be a 1-2 punch, first with psychotherapy counseling, seeing a psychologist, and learning to identify those things that may bring you down, and how you can kind of turn that outlook around. And then medication, okay? And we have a lot of medications that we can use to treat depression, a lot of them targeting this chemical serotonin, being the ideal one. But we know that one versus the other. If we use psychotherapy alone, it can help. Medication alone can help. But this combination of medication and psychotherapy, counseling, that combination is much more effective than either of these alone. And because when you're depressed, when you're apathetic, you're not going to be wanting to get up and go exercise. Once we start making those improvements in your mood, in your interest, in your energy, getting out and exercise, engaging in those social support systems, really more as a preventative tool to keep you afloat. So hey, if you're exercising and you're engaged, you're not going to dip down below that, back to that place where you were before. These are really kind of the preventative strategies in addition to the first two. And we want to keep you happy, of course. And so really moving over and talking about psychosis, which is psychosis is a tough word to just chew on. But psychosis, by that I really mean things like hallucinations, delusions, and illusions. And I thought this cartoon really was a good icebreaker for talking about hallucinations. And so one chicken is saying to the other, according to this research, hallucinations can actually improve cognitive function. The other chicken says, what research? And they find that it was a hallucination, that research. So it's important because each of these, hallucination, illusion, delusion, they can be used interchangeably, but it's good to kind of start to put some definition, give some a little bit more in-depth what this terminology means. And first and foremost, I'll talk about a hallucination, which is, hallucination is a feeling or perception of something there that is truly not. You don't necessarily need an external stimulus. You don't need to see something go by. It just matriculates. It's just there. And this can be in the fashion of visual hallucination, where you actually see something that's really not there, whether it be a person, whether it be an animal. A cat seems to be a common one, dog not as much. Whether it be an auditory hallucination or hearing somebody who's not there, hearing a loved one, especially a loved one who's since passed. Auditory is a little less common in Parkinson's than visual hallucinations, but by all means, we have to consider it when we start to hear those symptoms. And then there are these things called presence hallucinations. And presence hallucinations are that feeling, right? That feeling that somebody else is here. Somebody's in this room. Somebody's over my shoulder. And that's another important type of hallucination in addition to visual and auditory. Now, separating hallucination from illusion. Right? An illusion is a misperception of an external stimulus. So that means there's something, whether you see in this case a vase, something you misinterpret or misidentify. In this case, are we looking at faces? Are we looking at a vase? There's something that we just can't quite get around. And one of the examples of an illusion, because I trained in Pittsburgh, was this. And for the Pittsburgh Zoo and Aquarium, we see this logo all around town. And I was there for 4 years, and it wasn't until that fourth year that I realized that this was actually a gorilla on the left and a lion or tiger on the right that formed a tree. Totally baffled me. And it was a big aha moment. Then I felt, okay, now I can leave Pittsburgh. The more common one, and this is a common reference to delusion, is what you see here. So just to take a quick pause, how many of you guys see a duck? How do you guys see a rabbit? Okay, and so this is the trick. I mean, this is an illusion, all right? Your mind, in a way, playing a trick on you, misinterpreting one thing as something else. And lastly, I wanted to give the definition for delusion, because delusion is really separate from a hallucination or an illusion. A delusion is tricky because this is a fixed, illogical, and usually irrational belief, not based in any reality. All right, not based in any reality. So, for instance, this is like me saying that, I have problems moving my bowels because when I was abducted by the aliens, they fidgeted around a little bit in there. All right, that's a fixed false belief, and you can't rationalize with somebody who has that type of thing. I mean, aliens don't. No. It doesn't work. It's like trying to have an argument with somebody that is just not going to work out. But delusions that we see, and the ones we see especially in our patients with Parkinson's disease, and the ones that really hit home and affect everybody in the home, are things like delusions of jealousy, delusions of spousal infidelity, right? Thinking that, where were you? You were off with the mailman, or something of that nature. Delusions of maybe that, and paranoid delusions, maybe that, all right, well, my caregiver, they're locking me up, they're giving me these medications, and that's keeping me in the house, and that's really persecuting. And these are tricky, again, because delusions are that fixed false belief. It's hard to shake a delusion. So going back to hallucination and just saying that these are very, very common, 20 to 40%, not as common as depression in Parkinson's disease, but pretty common. And about 1 in 3 folks with Parkinson's disease will develop them. And they happen, or they're more likely to happen as the disease progresses, okay? And especially if as the disease progresses and as you're having any problems with thinking or thought or memory, these are all things that really put you at risk for having hallucinations and things we keep a close eye on. And just like I'm sure many of you know that when you're sick, when you're stressed, your motor symptoms of Parkinson's disease can get worse. The same holds true for things like hallucinations and memory. If you're stressed, if you're sick, if you're not getting good sleep, these are all things that can push you from a point where, hey, I'm doing pretty well, to now I'm having hallucinations. So it's important to realize. And it's also important to realize that not only, you don't have to be sick, you don't have to have Parkinson's disease for a long time, 10, 15 years to have hallucinations. It can also be pushed or even caused by some of the medications that we use. Anticholinergics, amantadine, Artane, these are things we use, which can really potentiate hallucinations. Antihistamines, which is a tricky one, because a lot of patients don't volunteer that I'm taking Tylenol PM or I'm taking Benadryl to help me get to sleep. That doesn't show up on the medication list. But these medications have things like anticholinergics, antihistamines that can really, really push you to have confusion, hallucinations. And then dopamine agonists. Dopamine agonists are the medications like Mirapex, Requip, which is ropinirole. These type of medications can also cause, in and of themselves, hallucinations. So hallucinations, and I wanted to stress this, hallucinations provide a really high level of caregiver stress. They provide, of course, a lot of stress to the person experiencing the hallucination, but that stress also carries over to the caregiver. And it's hallucinations that really come down to be the main risk factor for transitioning from the home to a nursing home, okay? So it's really important to do a number of things with hallucinations. First and foremost, you have to recognize them. Right? Recognize that you're having hallucination. Recognize that you're having a visual misperception or illusion, and bring it to our attention. And then what we're going to ask in clinic are, all right, these hallucinations that you're having, are they benign or not really bothersome? Or are they scary? All right? Do they incite fear? Do they incite anxiety? For instance, are you looking out the window and there's a cat there every once in a while? And you're like, I like cats, so it doesn't really bother me. I have a friend. Or you're looking out the window and you're thinking there's a robber. There's somebody who is out to get me out there. And it's very important to make that distinction between a benign and really more of a malignant or bothersome hallucination. Maybe not always needing to treat the former, but the latter. And then it's important to realize, and this goes back to that last slide, it's really important to realize if the hallucinations come out of the blue and really come out 0 to 60 miles per hour, because it could indicate that something else is going on. Maybe a new medication was started or medication was increased. Maybe there is a urinary tract infection or pneumonia or some sort of illness brewing that this is the first sign of it. I mean, this is the first sign of it and coming out in this hallucination, which people don't usually think, oh, I'm developing a cold or pneumonia, I'm hallucinating. That doesn't usually translate one-to-one, but it can in Parkinson's disease. And then before we move on to the next slide, it brings us to this cartoon. And this one chicken saying, how's your fever? The sick chicken says, fine. And the happy trees say my hallucinations have stopped. So that brings us to treatment options for hallucinations. And first and foremost, and it's really important, for just reorientation and reassurance, especially if they're just benign hallucinations. Because, again, not all hallucinations need treatment. Okay? There's going to be ups and downs in this road. But it's important to know that, all right, they're seeing a cat outside, it's not really bothering them. You don't need to put a medication onto. You don't need to kind of smother that. But it's important to identify when you do get to that point. And then two, and these are simple things. These are simple things that we probably don't do often enough in clinic, but we try to keep our eyes out for, is that, well, is there anything else, not just a Parkinson's disease, anything else contributing to how you perceive this image or how you perceive the things around you? And things like correcting vision, correcting hearing. These are little things that we can do to really hone you in and keep patients on the road so they're not swerving off and having hallucinations. And then if those don't work, those basic things, and if the hallucinations are persistent or fearful, one of the things we can do, and what we would probably like to do more often than not, rather than using a medication like an antipsychotic, is use a medication which improves cognition, improves your attention, kind of settles things down and improves that orientation towards where you are in the here and now. And some of those memory medications, and these are the same memory medications for mild cognitive impairment or Alzheimer's disease like rivastigmine or Exelon. These are the same medications that we like to use up front and center, because that can kind of get you to that point of, all right, I'm settling down, I understand the surroundings, and I'm not having these hallucinations. But if that doesn't work, or if the hallucinations are considerably bothersome, we can use medications, and these are lumped into that bigger category of antipsychotic medications. And the two that have been the mainstays for this are quetiapine, which is Seroquel, and clozapine, which is Clozaril. And these two have been the mainstays because a lot of other antipsychotic type medications can actually be really hazardous and harmful in Parkinson's disease, because they actually block dopamine. And we don't want to do that because there's already a deficit in dopamine. But these two are really our first line of medical treatment for hallucinations. And then now, as a lot of you probably are aware, there's pimavanserin, which is Nuplazid, which is a new medication now, which acts a little bit differently than these typical antipsychotics that we like to use, and can be advantageous for certain patients, but by all means not all. And because it's a new medication, we tend to run into the problem of cost of the new medication. So some of the take-homes are, first and foremost, that mood and psychosis. Everything I talked about, whether it be anxiety, depression, hallucinations, illusions, these things are common. These things are very common in Parkinson's disease. So it's very important to recognize them. Probably not as much as a patient, because it's going to be hard to recognize if you're having hallucination, but especially for caregivers, family, loved ones, to bring it to our attention that they're having them, because that's the first step in this, is identifying that problem. And while we do this, and while we try to tackle and implement some of these strategies to treat the hallucinations or the mood problem or the psychosis, it's really important, and we don't stress this enough, but it's really important as a caregiver to just make sure that, all right, these things that I'm dealing with, all right, hallucinations, depression, apathy, and my loved one, they're really tough. All right? They're really tough, and they can take a toll on you, especially as you're there for years and years at the bedside. So you have to take care of yourself as well, and that's probably not stressed enough, that as caregivers, I think you have to take care of yourself. And so I think just this past week, the National Parkinson's Foundation put out a nice little booklet, a nice summary about mood. There had already been one out about psychosis. We have stacks of these things in the center. And then at the center, we're fortunate to have Frances. We have a social worker on staff, and she's compiled a list of a lot of different resources, especially for caregivers to find some respite, maybe just a day program so you can get out and then come back pumped and ready to tackle this. Some good options for you. So here are some of those, and I know Frances, our social worker at the center, has a long list of them that we can always provide if asked. So thanks, and it's been great being here in Gainesville so far. I have one more year, so I'll probably see some of you here and there as it is. But thanks to everybody at the center, and thank you guys.